So I would like to thank the organization to let me a chance to present the topic about epilepsy surgery in a limited resource setting, sharing experience from Vietnam. I have nothing to disclose. I would like to send my special thanks to my mentors, Dr. Lê Văn Tuấn and Professor Lim Khang Sang, to support me. This is my outline. For the first part of my talk, I will talk about the current state of epilepsy surgery in ASEAN. As all you know that epilepsy surgery is one of the best effective treatment for epilepsy, especially for drug-resistant epilepsy. However, in USA, the surgery gap is up to 96 to 99%, or even in Canada, only 2% of patients with epilepsy refer to surgery within 2 years when defined as refractory. And in India, 200 epilepsy surgeries per year with over 500,000 potential surgical candidates. It means epilepsy surgery gap can up to 99.9%. And on the right side is from the epilepsy clinic in Malaysia, where you can see there are around 40% can get the seizure-free, which means drug refractory, and about a third of them can undergo to surgical evaluation. Half of them could go for surgery, and 60% get the seizure-free. So it means an addition around 3% can get the seizure remission with surgery. So surgeries is underutilized in both high income and lower and middle income. So in 2019, we published a paper about the underutilization of epilepsy surgery in Asian countries when I was epilepsy fellow in Malaysia. In this survey, we find out that epilepsy centers were available in 8 out of 11 Asian countries, except Brunei, Cambodia, and East Timor. However, in epilepsy center is mostly were at level 1 to level 3, which is provide basic and primary investigation such as video EEG or brain MRI. As you can see in Vietnam, we have totally 9 epilepsy centers. However, we have only 4 epilepsy centers at level 3, which could provide epilepsy surgery. However, they most related to brain tumor resection, and at that time we don't have much collaboration with the neurosurgeons. And when compared to the total population of Vietnam, around 90 million, it means less than 1 center per 10 million population. It implies that there are lack of personnel involved in epilepsy surgery in Vietnam. So beside the lack of personnel and expertise, we also find some barriers related to epilepsy surgeries. For example, for facility, we are lack of facilities, so we decide to share facilities among centers, which I will share more details in the next slide. And for expertise, we try to send our neurologists and neurosurgeons to finish epilepsy fellowship in experienced epilepsy centers, including Malaysia, Taiwan, or Korea. And we find the collaboration from foreign professors via teleconference from France and Malaysia. For clinical knowledge for health workers, we also organize epilepsy clinical course, which one collab with ASEPA or AO to raise the knowledge and awareness of epilepsy. Actually, we just organized one epilepsy clinical course in Thuy 2 days ago. And for patients, we try to open the Epilepsy Society and raise awareness of epilepsy in social media. For funding, now the national insurance subsidizes the cost of lumpectomy, including temporal lumpectomy, so patients somehow can afford the surgery. And after 2 years, we published a paper in Epilepsy Open in 2022 about the epilepsy surgery program in Ho Chi Minh City. We call it a multi-center collaborative model. In 2018, begin with the idea that we can share the facility, even the expertise among the different hospital and different centers, because we don't need all the center or all the hospital must do epilepsy surgery. For every region, we just need 1 or 2 hospitals can perform epilepsy surgeries to save the cost of training or the cost to buy the facilities. So we gather a group of specialists in different fields to a team. We call it the Ho Chi Minh City Epilepsy Core Team. We included neurologists from Nguyễn Tri Phương Hospital, neurosurgeon from Nguyễn Tri Phương and from UMC University Medical Center, 1 pediatric neurologist from Children's Hospital 1, and even the radiologist from PET City of Chợ Rẫy Hospital. We also include 1 psychiatrist and 1 pathologist from the University of Medicine and Pharmacy of Ho Chi Minh City. And for pre-surgical evaluation, as you all know, there are 2 phases. Phase 1, which is non-invasive, we provide the basic evaluation, will include long-term video EEG, brain MRI with epilepsy protocol. And for advanced evaluation tool, we can provide PET scan, functional MRI. Now we just do the motor function only, the tractography, the voxel-based morphometry. We can ask help from the Malaysia. And for phase 2, which is invasive, now we do the intraoperative electrocorticography to delineate or to optimize the border of the region. We hope somehow can make a better outcome for patient. And this is our timeline. After established Ho Chi Minh's Epilepsy Core Team in 2018, in 2019 we did the first standard anterior temporal lumpectomy. In 2022, the intraoperative ECOG was firstly introduced in Nguyễn Tri Phương Hospital and then UMC. And in 2022, the neurosurgeon can perform the corpus callosotomy by themselves. Actually, in the past, they had did the corpus callosotomy with the help of the French colleagues, but now they can do by themselves. And on the right is our algorithm. To be the very first step, so we decided to choose the surgical candidate with the best outcome, including the lesional MRI, which messiotemporal sclerosis, focal cortical dysplasia, and low-grade tumor. So we try to utilize the basic and primary evaluation, including the semiology, the interictal and ictal EEG from long-term video monitoring, and the brain MRI with epilepsy protocol. We hope to find the anatoclinical electrocorrelation to can get the epilepsy surgery. And this is our result. In 2 years, we recruited 52 lesional MRIs, and when we analyze the semiology, interictal EEG, and brain MRI, around half of patient, half of surgical candidate could go forward to the epilepsy surgery, which is the primary evaluation tool, and another half can did further advanced evaluation. Around 57% can undergo the epilepsy surgeries. So in conclusion, we have around 7 to 75% lesional MRI can go straight to epilepsy surgery with phase 1 non-invasive evaluation. And this is the result we published in the paper. Among 35 cases with surgeries, there is 25 cases with TLE, temporal lobe epilepsy. And as you see, we just only need PET scan in one case. The other, we use the semiology, inter-ictal, icto-EEG, and MRI to decide the surgery. And in general, we have at least 1 year to follow up, and around 29 among 35 patients had the outcome of NGO class 1, which is around 82% of the patient can get a good outcome, which is seizure-free. And this is the results we updated up to now. After 1.5 years frozen with COVID, after COVID, mostly in 2022 and first half of 2023, we did 29 more cases, which is around 80% was temporal lobe epilepsy. And as you can see, the result also similar, around 80 to 82% temporal lobe epilepsy and even extratemporal lobe can get the NGO outcome class 1, which is seizure-free. The corpus callosotomy, we performed 2 cases. As you know, corpus callosotomy is a palliative surgeries, so the cases did not have such a good outcome as the lesionectomy. So now totally we perform 64 cases. However, our program has also have limitation because we just started the epilepsy program for 1 to 3 years. So we need a long-term follow-up to see the long-term outcome